Okay, so we are going to get started with Dr. Hemant Sawnani, and he's just going to basically ask me to move forward the slides and advance the slides as we move along here. So Dr. Sawnani's presentation is How We Breathe and What Goes Wrong in Congenital Muscle Disease.
Thank you, Anne.
Join me here.
Yeah.
And here we go. I'm going to mute people. Give me just 1 second. If you have just calling in, if you can just mute your phone, that would be lovely.
Thank you. You know, I've tried to keep this somewhat elementary and to some of my almost boring, but you know, we've had some interesting perceptions of what plays into the perpetuation and downward spiral of restrictive pulmonary defects as growth and development occur. So in this short discourse, I think I'd like to cover just some basic relationships, what's normal breathing, and some structural changes and how that impacts normal structure change, normal function over the course. Next slide. So, you know, when you look at thoracic structure, which is slide 3, it comprises a set of ribs on each side of us, and all of those articulate beautifully with a central backbone, or the vertebral column, which comprises multiple little bones in perfect alignment. Now, what this allows is for a fairly disguised thoracic excursion with every breath. If we go to the 4th slide, you know, a simple schematic of what happens when we breathe. I explain to families that the chest is somewhat like a syringe. The plunger moves down, and that's what sucks air into us. So with the downward excursion of the chest, of the diaphragm, I beg your pardon, the air flowing into the chest actually causes expansion of the lungs and some displacement of the chest wall. The reverse phenomena occurs when we exhale, where you have some passive recoil of the chest along with the relaxation of the diaphragm, completing the exhalation process. Remember that expiration or exhalation is a passive process. We tend to burn calories primarily breathing in, not breathing out. Breathing out is a phase of relaxation. Next slide. So when the diaphragm moves down, there are 2 specific sets of movements for the ribs that take place with inspiration and exhalation. In the left half of the image, the ribs move upward and forward, and that increases the front to back dimensions of the chest wall. In the right half of the image, you see there's also a lateral movement or a side movement of the ribs, and that increases the lateral or the left to right dimensions of the chest. So when you add this to a downward excursion of the diaphragm, it effectively becomes a north, south, east, west increase in dimensions of the chest, and you may not realize it, but a simple breath in an average adult displaces almost 500 milliliters of air, and you don't even wrinkle your shirt when you do that. If anything, I think that's something to remember, because as I go through the next few slides, one of the things that tends to change is the first 2 portions of our respiratory movements, in that the rib movements and chest wall displacements are not as impressive as contracture begins to develop. And then we rely primarily on diaphragmatic mobility, and that's why we tend to see the belly breathing, so as to say, that occurs with more advanced muscle weakness. If we go to the next slide, we see what happens when we go from a vertical position to a recumbent position. When vertical, the orange downward arrow is pointing in the direction of gravity, and that pulls all the bowel contents off the diaphragm. So the diaphragm excursion is relatively unencumbered, and air rushes into the chest, which causes its usual displacements of the ribs and chest wall. Now, on the right half of the image in the upper portion is a supine position. I've merely turned the first image 90 degrees. So gravity doesn't change its sense of direction. What does change is the impact of settling of abdominal contents and a resultant upward displacement of the diaphragm. So the diaphragm assumes a higher resting position. When this happens, you tend to function at lower lung volumes, and there's less excursion of the ribs as well. The lower half of the image, what I did do was draw a triangle that pretty much outlined the vertical and the horizontal positions of lung volume, and you can see that we've moved from a very larger area under the gray triangle to a much smaller area under the orange triangle. I tell families when I point to this very large trash can in our visiting room, if I were to fill that with water and gave you a very large mug, then it requires maybe about 30 seconds to empty that can. But if I were to give you a little teacup, then it requires far many more breaths within the same period of time to effect the same effort. Next slide. These are 3 X-rays of the same child taken at 2, 4, and 6 years, not having congenital muscular dystrophy though. And what is not evidently apparent in the first inkling is more apparent when we go to the next image, where the red lines gradually tell the story of how bone structure changes over a period of time in neuromuscular disease. The ribs tend to be far more horizontal in early age, and as age, the disease either pushes forward or growth occurs or a combination of both happen, the ribs seem to take a much more horizontal, a less horizontal and more vertical orientation when compared to the spine. If we go back now to the previous slide, it becomes much more evident to the eye now what I was inferring to. So between 2 and 6 years of age, you can see the change in orientation of the ribs. So if I go forward to the next slide, to the impact of muscle weakness, there is a continuous interplay, on the flow sheet, on slide 9. There's a continuous interplay of the effects of respiratory muscle weakness and how it impacts or leads to respiratory insufficiency. On the left side of this flow sheet is the changes that take place in the lung, and on the right side is changes that take place to the skeleton around the lung. With respiratory muscle weakness, there tends to be a reduction of lung volume, and that impacts the ability to clear secretions. It's different to cough to clear your throat, and different to cough to clear secretions that are far deeper. So certainly it's the latter that gets more impacted early on. And over time, there are certain persistent lung changes that occur either by remodeling or by scarring from repeated infection. Meanwhile, there's a thought that some of the low lung volumes may also predispose to, thoracic wall changes, and the changes that we see in the rib cage and chest wall may either be primary to the disease or may be secondary from having low lung volumes. On slide number 10, it tells us of a downward spiral that tends to occur when the patient is faced with a combination of muscle weakness and rotational deformities that occur consequent to that or associated with that. There's diaphragmatic dysfunction because the diaphragm gets torqued horizontally. Consequently, cough is impaired. The patient tends to take shallower breaths and is more prone to fatigue, and that really sets up this persistent vicious cycle. Next slide. I just wanted to indicate and highlight something that I have a very significant and clinical interest in. There was a study that was published a few years ago, in about 2008. That's it. On a mouse model with muscular dystrophy with myositis. At 2 weeks of age, they were fairly similar, and about 6 weeks of age, there were marked differences between the two mice, where the affected mouse was relatively immobile and had much more skeletal deformity and spine deformity compared to the wild type. The next slide shows 3D reconstructive images. On the left side, it's the 2-week age, comparing both the wild type and the MDM model. And no significant difference is noted in the cross-section of the diaphragm, although the spine may appear to be a little more curved in the affected model. But if on the right side of the slide, if you look at 6 weeks of age, there's a marked discrepancy between the thoracic anatomy between both models. And when you look at the diaphragm cross-section, you can see how limited the diaphragm is in its footprint. I liken this to the difference between a 1 ml syringe and a 10 cc syringe. The amount of pressure a syringe is able to develop is obviously dependent on the square footage or the square area of the plunger. So a smaller square footage is going to be met with a less or lower net inspiratory effort when compared to an adequate square footage. The interesting thing is you can also see limitation of the lung volume on the right side of the affected animal, which also has a smaller right-sided diaphragm or hemidiaphragm when compared to its left side. So, the goal of keeping the lungs clear of secretions and trying to keep them healthy can be affected by some basic exercises or airway clearance modalities. The reason I threw a bottle of water in there is to really emphasize the point that dry mucus and desiccated mucus does not move. So hydration is very important for these patients. Let's go to the next slide, slide 14. I go back and forth in my mind when I look at the process that takes individuals from just pure muscle weakness to frank respiratory failure. And the things that come into play are scoliosis, which I believe can lead to lower breath volumes, or what we call tidal volumes, that lead progressively to lung volume changes. And when you have shallow breathing, worse during sleep, you tend to have a couple of additional pathologies, which we call hypoventilation and hypoxemia. Essentially what that means is elevation of carbon dioxide and lower oxygen levels. So when we breathe, we do two things. When you breathe in, you oxygenate, and when you breathe out, you ventilate, you get rid of the stale air. And when both of those processes are compromised, then the risks of developing respiratory failure are very obvious and elevated. So I wonder whether it is the scoliosis that triggers all of this, or if we go to the next slide, the scoliosis is actually heralded by low tidal volumes, and lung volume changes that predispose to a lack of development of the chest wall on that side, and then the subsequent pathology that tend towards respiratory failure. Last slide, second last slide. So whether it's the scoliosis that comes first or it's the low lung volumes that come first, I think it runs a risk of perpetuating itself. And our goal is to try and intervene at some point so that this downward slope doesn't continue, taking the individual from having simple pure muscle weakness to respiratory failure. Now, one of the things that we have identified is a presence of contractures in the little joints that articulate the ribs to the vertebral bodies. Just like we spend a lot, I tell my patients that you spend a lot of time stretching, ankles, knees, hips, elbows, wrists. There isn't a way to pick each rib and move it through its full range of motion like we can use, like we can do with the elbow or the knee. So we have an interest in trying to develop a mechanism to affect this much more effectively in the neuromuscular children. I'd like to end my discussion at this point and leave room for my other peers and colleagues up. And if there are any questions, I'd be happy to take some. I think that's a great question. So what degree of scoliosis impacts lung function? I think there is a couple of thoughts to that. One is I don't think it's a pure degree of this scoliosis. Regardless, too much of scoliosis is obviously going to impact it. So is there a critical threshold? I think that is a moving threshold, and it's often dependent on the level of muscle strength that coexists at that time, and any other deformities, and if the diaphragm is involved. If you have much more significant muscle weakness, you don't need 50 degrees of scoliosis to have respiratory effort, impact, but you may have maybe symptomatic at lower effort. The other aspect of this is lung function is usually compromised in sleep first rather than awake. So the impact of scoliosis, even though mild, might still exist, although it may be more manifest in sleep. So I'm not so sure I can put a number on what degree of scoliosis is going to be met with respiratory compromise, but I think it's a confluence of everything. When I see children with some amount of respiratory muscle weakness and scoliosis, my impulse is to immediately think of ventilation, maybe assess them with overnight oximetry and sleep studies, to really know whether that is clinically significant or not. But I think if it's going to be progressive with muscle weakness, I think it should be intervention for the spine should be earlier rather than later. So I would like to answer that in two parts. One is in the current literature, scoliosis surgery hasn't been shown to dramatically improve lung function across the board. But I think the next part of the question is, what do we do to affect normal lung function or to improve airway clearance, and will that translate into improved lung function overall once you have your spine more straight? So one of the things that I say to my patients is straightening the spine is one part. Keeping it straight and doing all the other airway clearance modalities is probably going to be of greater benefit than just only straightening the spine. In and by it itself, a straighter spine might not affect that much more lung function. We've seen a few, and I say that few as in a handful of children who were tracheostomy and ventilator bound actually after having some chest wall repair, meaning spine and ribs, come off the ventilator but still have a tracheostomy, but they're certainly able to come off the ventilator. So I do think that there are a few handful of children that do seem to benefit in a much more dramatic way, but the current body of evidence, I believe, does not support the idea that lung function will return to normal, but certainly I think it offers the protection against worsening or impending respiratory compromise once you stabilize the spine.
Great. Thank you so much, Dr. Sawnani. In the interest of time, we are going to move to Professor Simon's